Thank you. Okay. Good to start. You're ready to go.
All right. Good afternoon, everyone. My name is Muhammad Yaseen. Welcome to today's talk. We're going to talk about endocrine emergencies. So I'm really thankful to Dr. Hurst, who really helped me in preparing this talk. So I have no disclosure. So overall format for today is going to be, I'm going to talk about these 4 emergencies. I'm going to spend a good amount of time in hyperglycemia, about 25 minutes, I would say. And then we'll try to spend equal time in rest of 3 emergencies. So first of all, hyperglycemia. The reason I'm calling hyperglycemia as an endocrine emergency in ICU, because I think the hyperglycemia, managing hyperglycemia is equally important as managing diabetic ketoacidosis or hyperglycemic hyperosmolar state. And in next couple of slides, I would explain why I'm giving this much importance to hyperglycemia. So splitting it into 2 states, crisis states and non-crisis state. As far as the crisis state is concerned, DKA and hyperosmolar state, I'm not going to go into the details that most of us, we already know them. So I'm going to specifically talk about the cerebral edema, like how common it is and what are the risk factors associated and what is the pathogenesis and how we can avoid it. So that would be the main goal when we talk about the crisis state. As far as the non-crisis state is concerned, I'm going to explain briefly why it's a big deal in ICU. And number 2, what is the evidence behind and how this evidence evolved with the passage of time. And at the end, I will discuss the standardized insulin protocol that we use in the hospital. So that is the reason why we give importance to hypoglycemia in the ICU, because this study back in 2003 showed that the blood glucose level at time of presentation in ICU is actually associated with the high mortality. As you can see, if your blood glucose is in the range of 80 to 140, your mortality is somewhere between 10 to 15%. But if the blood glucose on presentation is more than 300, then your mortality is going to be almost 40%. So it's a risk factor for mortality in the ICU. And number 2, in this study, the mean and maximum blood glucose that were found during the course in ICU, they were higher in non-surviving patients as compared to the patient who survived. And then around the same time, the other study was published that basically focused on mortality, ICU mortality, the total mortality, and the non-ICU mortality. As you can see, the mortality is high in patients who have new hyperglycemia. That is 31% in patients who had new hyperglycemia in ICU, and the total inpatient mortality with new hyperglycemia was 16%. So pay more attention to new hyperglycemia because that is even a bigger risk factor. So it means no matter what is the cause of hyperglycemia, the mortality is going to be high, whether it's in patient with the diabetes mellitus, whether this is hyperglycemia in patient who are in a stressful condition like sepsis, or if this is hyperglycemia in the setting of steroids, or hyperglycemia, they are associated with the increased mortality. So if hyperglycemia is associated with the increased mortality, then the next question is controlling the blood glucose improves the mortality? So this is the list of the studies that were done in different times. The first 2 studies, they were in the ICU, but mostly they were in the patient who had like the cabbage. So in the cardiothoracic ICU, they found that there was 65% drop in the rate of infection in the patients who had better glycemic control. And the second study showed that there was a 57% drop in mortality in the same population in the post-cabbage setting. The third study in 2004, it was done in non-cardiac patients, and they were mixed medical and surgical ICU patient, and still you see there is a 30% decrease in mortality. And same is the study, the number 4 study that was done in 1995. So you still see the 28% mortality. I'm going to spend a little bit more time on the last study by Dr. Vandenberg that was done in 2001, because this was the study when it came out. It basically changed the way we manage hyperglycemia in the ICU. All the hospitals then they started developing the protocols for management of hyperglycemia. So what this study was, that it was done on 1,548 patients. It was a randomized controlled trial. The patients were randomized into intensive treatment arm and into the conventional treatment arm. And you can see what was the goal of blood glucose in those different arms. So at 12 months, you can see the ICU mortality is 4.6% in intensive treatment group as compared to the conventional treatment group, where the ICU mortality was 8%. If you look at the secondary outcome in the right bottom of the screen, the secondary outcome, the in-hospital mortality dropped by 34%. Bloodstream infections, they dropped by 46%. And then acute kidney injury needing hemodialysis also dropped significantly to 41%. And then the packed red blood cell transfusion also decreased by 50%. And then also there was a less like incidence of critical illness, polyneuropathy in these people. And as you can see on the left bottom of the screen, the survival in the ICU was better in the intensive arm as compared to the conventional arm. Now, this study, when it was published in 2001, although it changed the whole the approach how we manage hyperglycemia, but the limitation of this study was that no hypoglycemic episodes, they were documented in this study. And this study was not reproduced. The results of this study, that the intensive arm does better as compared to the conventional arm, this result was not reproduced later when multiple studies were done. And then finally, this study came in 2009. We know this study by Nice Sugar study. It was a quite similar trial, but now we have a bigger population of the patient, about 6,000 patients. It was done in multiple ICUs in Canada, New Zealand, and Australia. So these 6,000 patients, they again split them into the intensive arm and in the conventional arm. They basically used the units of glucose into the millimole. So in the intensive arm, the goal was 4.5 to 6 millimole per deciliter. If you convert that into milligram per deciliter, that's going to be somewhere between 81 to 108 milligram per deciliter. And the conventional arm, you have a blood glucose between 180 to 200. So they observed these patients for 3 months. And what they found that the hypoglycemic episodes, they were less frequent in the conventional arm. And 28-day mortality was less in the conventional arm, and it was also less like at end of 3 months. So in this study, we had improved outcome in the conventional arm with less hypoglycemic episodes. So when this study came out, then different societies, they actually made this recommendation then that we should aim blood glucose 140 to 180 milligram per deciliter. So that's the evolution, how we come across with this number. So if we look at all these studies, so the mean blood glucose level in these patients was somewhere between 140 to 150. And that's where if you keep your blood glucose level, the outcome is better. So the current recommendation is that blood glucose 140 to 180 milligram per deciliter. If we look at the population who are in like post cardiac surgery, their goal of blood glucose is a bit tighter. They aim their blood glucose more close to 140 because the rate of healing is better in those populations. And then the second recommendation was IV insulin is preferred over sub-Q insulin. Now, where this evidence come from, this was studied in 2019. I mean, there were other studies as well before this. So what they found that if we manage hyperglycemia with the IV infusion protocol, it is more likely that you're going to keep your blood glucose within the target range, and the blood glucose will get out of target range less frequently if you manage patient with the IV infusion protocols. And of course, you're going to end up checking blood glucose more frequently. So now, I am not going to go into a lot of details about what is the structure, how, what are the different components of these standardized IV insulin protocols. But the three main elements that I think we should be aware of is, number one, how the insulins are prepared. So insulin is prepared basically 1 unit per 1 ml of normal saline. So if you have 100 ml of normal saline, it would be 100 units in there. The reason is then you can easily titrate them by ml, 0.5 ml or 1 ml per minute. And then second point is how to decide at what rate we should start the infusion. We all have protocols, but in case we are at a place where we don't know, we don't have the protocol. So the rough formula is that you divide the initial blood glucose by 100. Like suppose if somebody has blood glucose of 650, so you divide that by 100, so it would be 6.5. So you will take the multiple, any multiple of, any near multiple of 0.5. So you will start like 6.5 unit per hour. So that's basically a rough formula. So you will give 6.5 units as a bolus, and then you start at a rate of 6.5. So that's the second point. I found that it's important to know. And then the third point is how we titrate these insulin infusions. We titrate that based upon hourly blood glucose when the blood glucose is not in range. But if it comes into the normal range, then we can widen that gap and we can check every 2 hours then. So that is all about the non-crisis state. So now I'm going to talk about the crisis state. So especially we will focus on the cerebral edema. So all of us, we are always concerned while we are managing DKA that this patient doesn't develop the cerebral edema. So this complication was first reported in 1936. And after that, multiple studies were done. Unfortunately, most of those studies, they have been on pediatric population. We do not have a lot of data on the adult population. I could find some case reports, some case series, some animal studies that we will go into and try to figure out and try to find the answers about the rate of correction. So as the first point is that the cerebral edema itself is not very common, sorry, into the adult population. If you look at this study, the incidence that was found was 0.03%. So that means like 3 cases in 10,000 DKA patients that you manage based upon this study. And this incidence is lower as compared to the incidence that we have in the pediatric population. So in pediatric population, your incidence is 0.5 to 9%. But as far as the mortality is concerned, the mortality is higher in adult population as compared to the pediatric population, 35% as compared to 24% in the pediatric population. And the other point that this study showed that the people who had high comorbidity burden at the time of DKA and HHS, they were more likely to develop the cerebral edema during the treatment. So while managing these patients, a common question we always ask, hey, what is the appropriate rate of glucose correction? We will try to find that answer, but at the same time, we should also look at other question as well, that how to control the rate of correction. I think both of these questions, they are equally important. And I'll go through them one by one. So as far as the rate of correction is concerned, I was able to find some adult data, but I couldn't find any like well-designed randomized studies, or there are no meta-analysis that have been published in the past in adult population. I could find one case series that was like a while ago in 1986, comprised of 5 patients, and there were 7 case reports so far. I think the last one that I found was 2018 or 19 in, it was published in the American Thoracic Society Journal. Okay, so based upon the case series of 5 patients, you can see the results on the left. The people, these 5 patients who developed cerebral edema, all of them, they had initial blood glucose around 500 plus minus 300. So blood glucose is pretty high on admission, number one. And number two, the initial osmolality was also very high, about 380 plus minus 30. So we can derive from this that people who have high blood glucose in the beginning, high osmolality, they are the more likely to develop this cerebral edema. But the interesting finding you can see, because the notion has been throughout the history that the rapid blood glucose correction, it increases the risk of cerebral edema. So they try to control the blood glucose in these cases with a slower rate, and the rate was like 38 milligram per deciliter per hour. That's very slow, but still the cerebral edema developed in these patients. And the fourth point was that in all of these patients, the blood glucose was less than 250 when they developed the cerebral edema. So this is an interesting finding in this case series. If you look at the case reports, 7 case reports, there were some case reports in which the cerebral edema developed with the rapid correction, and in some it was not. So there was not a consistent relationship between the rate of drop of glucose and cerebral edema. And mostly 5 out of 7 patients, they had new onset diabetes. And then most of these patients, they were younger, like 20 to 30 years of age. And all of these patients, they had altered mental status on presentation. So this is the only data I could find. And these are the risk factors that I could get out of these studies. Now, that's the human data. If I look at the animal data, this study was originally published back in 1965. And again, this was published in Journal of American Society of Nephrology in 2000. So it's important to understand this study, but this was done in rats. So they had 3 groups of rats. In all the groups, they exposed them to hyperglycemia. So all of them, they had 4 hours of hyperglycemia. In the first group, they rapidly dropped the blood glucose from 1100 to 500. As you can see, it's a rapid drop. They dropped that using with the insulin, but no cerebral edema developed. Although this is a rapid drop, but no cerebral edema developed. In the second group, the same group, 4 hours of hyperglycemia, rapid drop, but at this time they dropped it from 1000 to 180 milligram per deciliter. So the drop is less than 250. So the cerebral edema developed in these patients. And then the last group, again, the same group, 4 hours of hyperglycemia, rapid correction from 1000 to 200. But the cerebral edema does not develop in these patients because the drop in this group was from the dialysis, not from the insulin. So you can get a conclusion from that insulin has some role in developing the cerebral edema. So that was an important point from this animal data. So if we summarize the conclusion from both of these studies, so if you look at the animal studies, what says cerebral edema is not associated with the rate of drop of glucose, but it develops if you drop your glucose less than 250. On the other side, from the case reports and case series that I mentioned, again, there was no consistent relationship between the cerebral edema rate of blood glucose drop. And again, the cerebral edema developed when the rate was less than 250, when the absolute level was less than 250.
Quick question. Did either of those studies look at the rate of osmolar or osmolality change?
No, it was basically just glucose. They did not look into that parameter. So,
does the osmolar change in the glucose level, the sodium level, is it associated with a rapid change in sodium level?
Well, this study, the case reports are mentioning, they didn't mention about the osmolality, and even the animal study, they just study the one factor of the changes in the glucose. So yeah, that's a good point that we don't have that how the sodium was behaving in these studies. So these are all the limitations of these studies. So these are the conclusion here. So we can have this, there is one approach is that based upon these studies that if you believe in this, that rate of glucose correction is not related to cerebral edema, then aim the blood glucose higher, like 250 to 300. Do not drop your blood glucose less than 300 milligram per deciliter until your osmolality is corrected. Like suppose you have blood glucose of like 900, but at the same time, once you're correcting, your sodium level is going up and it's like 150 or 160. So keep your blood glucose level above 250 to 300 until your sodium is correcting and the osmolality comes in the normal range. And once it comes in the normal range, then you can drop the blood glucose to less than 250. So that is the one approach based upon these studies. And I have met people who believe in this and they practice this way. But the real question comes when we are dealing with the patients who have high risk factors. So as you can see on the left, we have the risk factor in the pediatric population, and on the right side, we have risk factors in the adult population. Now the question is what we should do if I don't believe in the approach one, what is the other approach that I can like adopt or follow? Now, this was an interesting point that cerebral edema, it developed only in patients who were treated with insulin. It didn't develop in the patients who were treated with dialysis. So that led to the point that insulin has something to develop with the development of cerebral edema. So it's very important to understand how we control the rate of correction, to understand the physiology behind. As you can see, the blood glucose in the blood, it comes from two sources. It comes from your diet, and it comes from the metabolic pathways in the body, like glycogenolysis and gluconeogenesis. So that these are two processes that add blood glucose. How the glucose get out of the body is the urinary excretion. When it's extra, it excretes in the urine, and at the same time, it's transported inside the cells when there is insulin. So if you have insulin, when you give insulin, it will suppress the glycogenolysis and gluconeogenesis, and it will promote cellular uptake. That's how it manages the hyperglycemia. So you will have the drop in blood glucose. But at the same time, if you give IV fluids at the same time, the IV fluid is gonna affect in two ways. Number one, patient might be in state of shock when he came, and there is not enough renal perfusion. So once you give glucose, now the renal perfusion is improved, and now the blood glucose is going to be excreted into the urine as well. So that's an additional factor that's causing the drop in the blood glucose level. At the same time, when you give fluids, it affects the stress hormones as well. It's going to drop the stress hormone levels, and that's another factor that causes the hyperglycemia. So the point I'm trying to make is that when you start insulin and IV fluids both together, just in high doses, then you are not going to be able to control the rate of glucose correction. So if you really want to control the rate of glucose correction, one of the other approach could be that start with the fluids first. If the patient is not markedly acidotic, start with the fluid first and see how is the rate of drop of blood glucose. And once the patient volume status is optimized, you can start the insulin then. If you don't agree with this approach and you're worried about the acidosis, maybe you can start fluids and low dose of insulin at the same time. Don't start the high dose so that to some extent you can control the blood glucose. So the point I'm trying to make is if you don't believe in the approach one, that the rate of glucose correction, then try to control the blood glucose rate with one of these two approaches, like just give the IV fluids first, and then use the insulin, or give the IV fluids and low dose insulin in the beginning. And then once the patient volume is optimized, then you can adjust the rate of insulin then. So these are the important points. Again, we do not have, these approaches are just like people are following these different schools of thoughts. These are not called expert opinions according to the literature, and these are not recommendations. We don't have any recommendations regarding the rate of glucose correction and osmolality correction. The number that we usually hear, that 100 milligram per deciliter per hour, or osmolality 1 to 3 millimole per liter per hour. Again, there is not strong evidence, and whatever evidence we have, that comes from the pediatric population. So we do not have any direction on the adult population. All right, so that concludes my my talk about about these hyperglycemia. Any question about this before we proceed?
I was thinking that study because, you know, again, if you think about the pathophysiology of how patients develop, it's not the glucose itself, right? Because you see this happen in hepatic encephalopathy, you see all kinds of manifestations. It tends to correlate pretty tightly with osmolality, just like you said, in the pediatric population. There's clear evidence of that. So it'd be interesting to see if anybody would look at that and see if that actually is
Right.
sort of the triggering factor for all of this.
Yeah, sure. It's not just the glucose; it's the overall osmolality, because it's about sodium as well. Because when the people, they are hyperglycemic, they are losing a lot of free water, and that's caused the hyperglycemia. And that's where the second approach is kind of making us think about that. Do not drop your osmolality too quickly. Just with the IV fluids in the beginning, you are controlling basically the osmolality and not doing much with the hyperglycemia. But once your osmolality comes down, that's when you start dealing with the hyperglycemia then. And again, there are no fixed directions.
This is where we're seeing a lot of patients that come in beside glucoses, and a lot of people just a protocol, right? So we give an insulin, fluid, and all that at one time. And so many times where the serum osmolality is not checked. So we're really trying to kind of re-educate on that, that reflex, just to click the box and, the nursing protocol carries itself out. But really to kind of think about where you are at baseline. You can take it slowly. You don't have to rapidly correct these patients in both situations. So,
I am like strong advocate behind serum plasma and that works that because I usually add it on or I have to.
Yeah, it's not part of it.
Yeah, it's not part of the protocol. And I think it gets under-recognized until there's a devastating intracranial event that it's too late for us to intervene. So I appreciate that because that heightens awareness. Maybe a little bit more attention to serum osmo might be important for us.
Years ago, we had that up with a young guy, because they're young, right? They don't have cerebral atrophy of our older patients, so there's no room in that cerebral edema, so they permeate relatively quickly. I remember going over that case, and we took it to epidemic at the ED as well as the ICU.
The most difficult DPA patient I think is the patient that comes in with glucose of 1200 and had a sodium of 148.
And as you correct, the sodium goes up.
Exactly. And so that is another example where having the serum osmo is so key because that will help you with your rate of correction. Some people will also be normal and maybe they'll forget that they have to correct for in the sodium of 160.
They did the labs, the order stuff, or should be a serum osmo.
Yeah, I think we need to add the serum osmo to the order set.
It's almost like a hard stop. It doesn't let you just order the script without a insulin bolus.
Yeah, you have to order it, and I tell the nurse.
Quick question from the Zoom sphere. What would you think would be a reasonable serum osm correction within a 24-hour period? Whether we're going to administer fluids initially and then treat the hyperglycemia. What would be a reasonable, not target to overshoot? Is there any evidence on a specific, or at least any literature published on a specific osm goal that you can titrate towards, or like a delta over a certain amount of time? Or, should we use a lower insulin infusion rate, or should we administer insulin at the 0.1 kgs and give dextrose if we're going too fast? Or, I feel like, I know you said there are two schools of thoughts, but what's your thought on that?
I mean, if we look at the evidence, we do not have any fixed number, like correct at 100 milligram per deciliter of glucose or correct at a rate of 1 to 3 milliequivalent osmolality. There is no fixed number in the literature. But what I'm advocate of, I think, pay attention to both approaches. Try to control the rate. That's the key, and make sure in the beginning, try to evaluate the patient. If you think the patient needs more fluids, try with the fluid first, because the people that don't die from like just the insulin deficiency, they're going to die from like the severe acidosis and die from the volume depletion. So if you're coming into a situation where the patient is severely volume depleted, but acidosis is not a big factor, and osmolality is high, so it means in those patients, you can correct the hypovolemia first. And again, I don't have any number which I can say that aim 100 milligram per deciliter per hour, but I would initiate with the fluids first if the patient is not markedly acidotic. Or if acidosis is a concern as well with the fluids, I would start low dose insulin as well, not following the typical protocol where if the blood glucose is 600, you start at 6 units per hour. I would maybe gentle in those patients.
I wonder if the rise in sodium after glucose is corrected prevents cerebral edema from occurring.
Sorry, can you repeat?
The rise in sodium as glucose is corrected, perhaps that's helps stave off cerebral edema. Because I'm thinking we're trying to prevent cerebral edema in patients, and the answer would give them hypotonic solution.
Well, the sodium that is worsening when you are correcting is hyperglycemia is all just the movement of water. You are not actually changing the sodium. You can call it a translocational. So you are not changing the composition of free water when you're just dropping the glucose level. So the real changes in osmolality are going to reflect when the hyperglycemia is completely gone. That's when you will focus more on the free water supplementation. So, but I didn't find anything that it's going to protect or it's going to worsen this cerebral edema. All right, so I think considering we have not much time, let's proceed. So we can talk later. All right, so thyroid emergencies. I'm going to talk about thyroid storm and mixed edema coma. So this is just a simple physiology. As you can see, hypothalamic, pituitary, and thyroid axis. But the 4 key steps that I'm in the synthesis of the thyroid hormones that we need to know, because these are the steps that we target when we are managing these patients with the thyroid storm. The first step is transport of iodine into the follicles with the help of a transporter. We aim this step with the iodide load that we use during treatment of thyroid storm. The second step is synthesis of these thyroid hormones with thyroid peroxidase enzyme, and we target this enzyme with the anti-thyroid drugs, propylthiouracil and methimazole. And then these thyroid hormones, they are released into the circulation, and we target this step with the help of steroids. And then the last step is basically conversion of T4 to T3, and we target this step with again with the help of steroids and with the help of beta blockers to some extent. So it's important to know some pathophysiology behind. Now, what is the difference between thyrotoxicosis and thyroid storm? No, both of them, they have elevated T4 and T3 and suppressed TSH. But the key difference is the degree of adrenergic stimulation. That's the key feature that is more pronounced in thyroid storm, and that's why the patient go into the thyroid storm state rather than the thyrotoxicosis. So that's the important point to keep in mind when we are dealing the thyroid storm, that they have more adrenergic stimulation. As far as the epidemiology is concerned, it's a life-threatening, very rare condition in the ICU, 0.2 per 100,000 in general population. But if the people, they already have, if they are admitted with a thyrotoxicosis, the chances of developing this thyroid storm are about 5.4%. And then again, the mortality is high because all of these patients, they develop multi-organ failure and cardiogenic shock. So if people have this, then they're going to have worse outcome. So as far as the clinical presentation is concerned, non-specific, most of the time it mimics the other disorders, mostly some kind of neurocognitive disorders. You might see psychotic symptoms more pronounced in these patients, or sometimes you can see intracerebral infection or some inflammatory phenomena, meningitis, encephalitis. You might be suspecting that. And sometimes it's just the hyperthermia is more prominent feature. And then cardiac manifestations as well. They might be in AFib with RVR, they develop VTAC, cardiogenic shock. So keep those things in mind as well. So very non-specific signs and symptoms. But what is going to help you is the GI symptoms, associated GI symptoms, and then symptoms at the end like weight loss. Patient must be losing weight recently, and then tremors, restlessness, anxiety, agitation, and then again, if it's a long history of thyrotoxicosis, you might see the exophthalmos as well. So keep all these signs in mind. But again, as far as the diagnosis is concerned, both thyrotoxicosis and thyroid storm, both of them, they would have suppressed TSH and high thyroid hormones. So not able to differentiate between them. So in order to differentiate, we have this scoring system that's called Birch criteria. So this gives a score based upon involvement of different organs, as you can see on the right side of the screen. And depending upon the patient signs and symptoms, you will add up all that score. And if that score is more than 45, then it's a high likely of thyroid storm, and then you will start treating patient based upon the thyroid storm. And then if it is between 25 to 44, there's a moderate kind of chances that this patient has thyroid storm. But if it is less than 25, then the thyroid storm is less likely. Now, as far as the risk factors are concerned, underlying thyroid condition, it's more associated with the amiodarone-induced thyroiditis. 33% of those patients can go into this thyroid storm. The second more common abnormality, underlying pathology is a Graves' disease. And then you can see the rest as well, but they have relatively lower chances of underlying pathology. As far as the precipitating factors are concerned, any stressful state, whether it's a form of surgery, is form of infection, and any form of trauma in a patient who has previous history of any hyperthyroid state, they can develop this, they can go into this decompensated phase and thyroid storm. The two important elements to remember, factors that can precipitate are at the bottom. Radioactive iodine treatment is one of the risk factors, and the other is iodine containing contrast materials that we may end up using on some of the patients in the ICU or on the floor. So keep that in mind. Those are the risk factors for development of thyroid storm. As far as the management is concerned, so our goal in thyroid storm is basically to minimize the adrenergic effects of this thyroid storm. So the use of beta blockers, they will directly block the effect of adrenergic system. And you can see the propranolol is the drug of choice, 60 to 120 milligram every 4 to 6 hours. So you need like more frequent beta blocker dosage in these patients. Use of steroids is also evident in these patients, and the goal is to prevent the release and prevent the conversion from T4 to T3. And another step would be to block the synthesis of these enzymes, of these hormones by using the anti-thyroid drugs. And those two drugs that we're well aware of are propylthiouracil and methimazole. And then we have these iodine solutions as well, and lithium is also used in these people. And then this is something new that I found at the bottom, that cholestyramine is also used because it increases the GI excretion of these thyroid hormones. So this is also one of the treatment modality that is used in thyroid storm. But blocking the adrenergic system is the key in management of these people. So the people who have multi-organ failure, depending upon QSOFA or SOFA, they have worse outcome, as you can see on the survival curve. And the people with a cardiogenic shock, they will have worse outcome as well. So moving forward to mixed edema. The first point, this mixed edema coma, the term is a misnomer, because these patients who we call the mixed edema coma, they might not have edema, or they might not be in a comatose state. So it's a kind of misnomer, but it's okay to use it because it's common in literature, but it's a misnomer. The correct way the correct term would be like compensated hypothyroidism or decompensated hypothyroidism. If the organ is working at a suboptimal level, you can call it compensated. And if it's like already failed and not working at all, then it's a decompensated hypothyroidism. So decompensated hypothyroidism is equivalent and better term as compared to mixed edema coma. So that's a key point on this slide. Epidemiology, again, very rare condition, 0.02 per 100,000 population, just like the hyperthyroid people, like thyroid storm. It's also a rare complication, and high index of suspicion is needed to diagnose this problem. Again, mortality is high. Once patient has mixed edema coma, mortality can go as high as 60% if you don't have the intensive treatment measures. Despite intensive treatment, 1 out of 4 or 5 patients are going to die. So it's that lethal condition. Clinical manifestation, it affects all the system, mainly neurological system. So you can remember it like slowing of the neurological system. The patient might be from just lethargy to a comatose state. But some case reports have been reported in the people presented with psychosis, like they're kind of agitated, and you may suspect now it could be hyperthyroid, but psychosis, there was one case report reporting psychosis. There was a case report patient presented with the status epilepticus as well. And when the LP was performed in those patients, they indicated that the pressures were high and the protein count was also high in these patients. So it may make you think about some like pathological problem in the CNS. As far as the cardiac system is concerned, decreased cardiac heart rate, decreased contractility, these are the main manifestation, prolonged QT interval that may proceed to VTAC and torsades. And then pericardial effusion. Hypothyroid patients, they have evidence of pericardial effusion. They may develop pleural effusion. They may develop even ascites as well. Respiratory system is muscle weakness, and they develop type 2 respiratory failure, like hypercapnic respiratory failure. They might need respiratory support as well. And GI also slows down, like constipation, ileus, and then increased risk of bleeding. Increased risk of GI bleeding is because, as you can see, there is a hematological effect of this hypothyroid state as well, that it increases the risk of risk of overall bleeding because of acquired von Willebrand syndrome, acquired von Willebrand deficiency, and then deficiency of the other clotting factor. I didn't go into the reason why it happened, but that was something new for me that I found. So as a result of that, it increases the risk of GI bleeding as well. And then these hypothyroid patients, they have a high incidence of hyponatremia as well. That's why euvolemic hyponatremia, we rule out the hypothyroid state as well. Again, diagnosis is challenging because there are a lot of other conditions that can mimic it. Adrenal crisis itself, hypoglycemia itself from any other cause can mimic the mixed edema coma. Hypothermia from any other cause, heart block or any cardiogenic shock from any other cause can mimic this state. So very difficult to diagnose. So you need something additional to just T3, T4, or TSH. And again, we have this diagnostic scoring system again, based upon different system involvement, you calculate the score. And if that score is more than 60, it's high likely of mixed edema coma. If it's less than 25, it's less likely that. So again, very difficult to diagnose, but it has high mortality and high index of suspicion is needed. As far as the treatment is concerned, so we'll treat the cause. So don't forget the cause that precipitated this event. It might be infection, it might be sepsis or recent CVA, or it might be acute coronary syndrome. So any stressful state can put the patient into that decompensated state. So treatment of the under cause is equally important. Supportive care depend upon what manifestation the patient is having. If it's a hypothermia, we need to warm that patient, active warming, passive warming, whatever facilities we have. If it's hypoglycemia, we need to give dextrose. Hyponatremia, we need to manage depending upon what the volume status is, and whether the patient just need a fluid restriction or patient need hypertonic saline, depending upon how severe is that. And then cardiac support, again, depending upon what state the patients are. They may need like the butamine or milrinone, or maybe the device therapy as well. And then hematological support as well, because they might have the clotting factor deficiency that's causing bleeding. As far as the actual treatment, definite treatment is concerned, is the hormonal replacement. It's basically T4 replacement. That is the backbone of the therapy. And always rule out any cardiac condition like acute coronary syndrome before you give T4. And people who have high likelihood of developing MI on this, maybe use a lower range of the dose in those patients. The loading dose is 200 to 400 mics, and then the maintenance dose is about 1 mic per kilogram per day. And then you can use a T3 replacement as well, but not needed in all the patients. If the people are very sick, you can use T3 replacement, keeping in mind that it will basically increase the chances of cardiac toxicity. So only use in those patients which are very sick because of the hypothyroid state. And once you start seeing that the patient are improving, then try to stop T3 before you stop the T4. So try to come off T3 before once the patient starts improving. And the dose is 5 to 20 mics IV, and then the maintenance dose is 2.5 to 1 mic IV every 8 hours. So, and once you start the treatment, then we follow up with the thyroid hormones, which are T3, T4, and TSH. The TSH basically tell us if you have given enough T4 or not. The T4, the TSH level should improve at a rate of 50% per week. Like by the end of the week, there should be a drop in the TSH level by 50%. If that's not happening, it means you're not giving enough T4. So maybe you need to go up with the thyroxine replacement. Free T4, it also helps us because in the hypothyroid state, the T4 is just negligible or maybe absent. So the T4 should normalize within few days, within 4 days. If it's not happening, then it means you need to give more T4. And then we check T3 while we are giving T3, because if your T3 level come back high, it means you're giving too much T3 and we need to cut back down on that. So that's the significance of monitoring these hormone levels. Okay, so the last is adrenal insufficiency. And then when we talk about adrenal insufficiency, just from understanding standpoint, split that into like two conditions: the conditions which have absolute cortisol deficiency, and the conditions which have relative cortisol deficiency. The conditions which have absolute cortisol deficiency, we know them by primary adrenal insufficiency and secondary adrenal insufficiency. But on the other side, the relative cortisol deficiency, we don't use this term, but you would see this term as well. But the actual term to use in this kind of condition is critical illness-related corticosteroid insufficiency. The real challenge in the ICU population is that it's hard to differentiate, accurately diagnose whether this patient has pure adrenal insufficiency or whether this patient has this corticosteroid-related, critical illness-related corticosteroid insufficiency. I'll comment on that in the later couple of slides, but this is the whole spectrum of adrenal insufficiency in the ICU population. Clinical features depend upon which of these three hormones is deficient in the body. If it's a low in case of primary adrenal insufficiency, you will have deficiency of all three. So you will see all these manifestations in those patients. People with the secondary adrenal insufficiency, they have intact aldosterone system. So you might not see the signs of this low aldosterone, especially the potassium would be normal in those patients who has secondary adrenal insufficiency. And then based upon whether the sex hormones are deficient as well, you will see those signs as well. So it's very important to differentiate whether we are dealing with the crisis state, or I think the main point that we need to differentiate is whether we are dealing with a crisis state or whether we are dealing with a non-crisis state. If you only have the signs and symptoms that I mentioned in the previous slide without any hemodynamic compromise, that's your non-crisis state. And then the next question would be whether it's a primary or secondary or whether it's a critical illness related. But if it's a crisis state, that all of those patients would have hemodynamic compromise. But remember, there is another state as well that lies in between two. It could be, you can call it like impending crisis state or incipient crisis state, when you have severe manifestations but still don't have the hemodynamic compromise. So keep that entity in your mind as well. If you have severe clinical manifestation, even with the normal hemodynamic system, suspect that and treat them as you are treating the decompensated or the crisis state. All right, so that's the slide now, that why diagnosing adrenal insufficiency in ICU is challenging. It's because of the three factors. Number one, in ICU population, the real problem is that the cortisol breakdown, it slows down. So you will have high cortisol level. So you cannot depend upon all the diagnostic tests that depend upon serum cortisol level or ACTH stimulation tests. Those tests then they become biased then. Number one. Number two is we need to understand this hypothalamic pituitary adrenal axis. It behaves like strange in case of critical illness. In the first week, this axis is very stimulated. In the first week of any critical illness, in that state, both ACTH and cortisol level would be high. But after 1 week, then your ACTH, it starts going down, but cortisol still stays high because as you remember, the first step is it breaks down, slows down. So you still have high cortisol level in these patients. And the number three is that this cortisol, it's free in the plasma, but at the same time, it has bound form as well. So you don't know if you are gonna monitor like the free form or you're gonna monitor the bound form of this cortisol. So these three factors basically make it very challenging diagnosis in case of ICU population. And the key point I mentioned at the bottom is because of all these factors, there is a lack of consensus among what is the optimal level in this ICU population. And if we are measuring it, whether we should measure free cortisol or whether we should measure the bound cortisol. And again, those levels are not clear as well. The European Society of Critical Care and the Society of Critical Care Medicine, they updated, I think 2018, their guidelines. But again, they were not very informative in, they were not strong. They are informative, but they are not strong favoring one or the other. I could find this scheme from another article that was published around the same time when they were updating these guidelines. And they have reference of this article as well in their guidelines. So in the ICU population, if you are suspecting adrenal insufficiency during the critical care illness, the first point to see is the patient hemodynamically stable or unstable? If the hemodynamically patient is unstable, if the patient is in septic shock, you cannot rule out or rule in adrenal insufficiency in those patients. Septic shock patients, if they need steroids, you just treat them as they are adrenally insufficient. But if the condition is that patient does not have septic shock, but still hemodynamically unstable from other parameters, so in that case, you can check this random cortisol level. Now again, this cortisol, it is bound to the plasma. It's bound to the plasma protein as well. So the test depends upon what is the albumin level. If your albumin level is more than 2.5, in that case you can measure the total cortisol level. And then if that cortisol level is more than 15, that rules out it. But if it is less than 15, that is telling you that this is a state of adrenal insufficiency. And if you are sure, you can go ahead and treat this patient with the steroids. But if not sure, then the next step is going to be corticosteroid stimulation test. Now, again, on the other side, if the patient is hemodynamically stable and you have albumin less than 2.5, so you cannot rely on total cortisol in those patients. So go with the free cortisol level in those patients. And the cutoff in those patients is going to be free level less than 1.8 microgram per deciliter. In doubt, go ahead and get this cosintropin stimulation test. So after giving this ACTH, you measure the cortisol level. And I have mentioned those values over there. In case of hypoalbuminemia, the level more than 15 indicates adrenal insufficiency. In case of no hypoalbuminemia, level more than 22 will indicate adrenal insufficiency. And if you check free cortisol level after this ACTH stimulation, then your cutoff is going to be 3.1 microgram per deciliter. So I found this slide very informative. But I think the key is that we cannot diagnose septic adrenal insufficiency in septic shock, and in the non-septic shock condition, that is the approach that you will use. Now, management of adrenal crisis is basically treat the underlying cause. The key is replacement of steroid with the hydrocortisone. The dose is 200 milligram, 100 milligram to begin with, and then 50 milligram every 6 hours. That's the key. And then if hydrocortisone is not available, then we have the other steroid as well. And I have mentioned their doses there too. And also they need the fluids. And the one key point is that if it's a pure adrenal insufficiency or adrenal crisis, it should improve within 1 to 2 hours of starting the steroids and fluids. If it doesn't happen, suspect septic shock or some other etiology that you're dealing with. So I think then I will finish with just the take-home points. Number 1, respect hyperglycemia as you respect DKA and HHS. That's a key point. Do not drop blood glucose less than 250 to 300 until osmolality is corrected. And try to pay attention to how to control the rate of glucose correction. Thyroid emergencies, they have high mortality, but rare and difficult to diagnose. So high index of suspicion is needed. Be careful when you're giving iodine-containing contrast to patients who have hypothyroidism. They may go into thyroid storm. And then use algorithmic approach to diagnose adrenal insufficiency in ICU population. So that's all what I have. Any question?
For mixed edema coma, for patients, what is the general response time, do you feel, for patients who have like significantly altered mental status or, uptended patients, like how quickly do they recover?
Are you talking about the adrenal insufficiency?
No, for mixed edema coma, for hypothyroidism. Decompensated hypothyroidism.
No, I don't know any timeline as far as the neurological status is concerned. Sorry, I don't have any direction. Thank you.